everyone, I'm Kathleen, a third year student respiratory therapist, and today I will be presenting my clinical case study. This is baby Mo, a cutie who unfortunately has a case of respiratory distress syndrome, or RDS. RDS is a condition that mostly concerns baby Mo's lungs. That is when we, respiratory therapists, come in and support our little Mo. We help him open up his lungs, support his breathing, and oxygenation. Let's take a closer look at our baby and find out how or why this is happening. Mo is a baby Qatari boy born on February 18, 2021, via elective cesarean at 38 weeks gestation. He weighs 3.03 kg and is 55 centimeters tall. Pre and perinatal history reveals maternal risk factors of gestational diabetes mellitus, hypothyroidism, anemia, and asthma. There is no mention of any family history. On birth, baby boy was normal and healthy, with an APGAR of 9 at 1 minute, then 10 and 5 at 10 minutes. No abnormalities were detected on examination and was given to mom for skin to skin and breastfeeding. 2 hours after giving birth, baby Mo started to have grunting, nasal flaring, and chest retractions, with vitals as follows. Note the decrease in SpO2 of 89%. Despite giving oxygenation of 30%, baby's grunting worsened. Grunting is actually the baby's attempt to maintain FRC of his collapsing alveoli. That is why we decided to put him on CPAP of 7 on FiO 2.25 to open up his lungs and or alveoli and support oxygenation. With respiratory rate reaching to high 70s, baby did not improve and a decision to put the baby on NICU was made. Antibiotic course will be initiated until culture status is known in case of infection. At this point, we will be doing tests to identify what is happening to our little Mo and eliminate differential diagnosis. Chest x-rays and blood works to be done. Current differential diagnosis includes RDS, transient tachypnea of a newborn or TTN, and or congenital pneumonia. Let's review the systems and investigate. Review of systems. Cardiovascular-wise, baby is hemodynamically stable with normal heart sounds. Respiratory-wise, he is on CPAP as mentioned, but still tachypnic, reaching respiratory rate of 90s with evident grunting and retractions. Beside respiratory, other systems are otherwise normal. On chest x-rays, there is no sign of focal consolidation, but rather reticulogranular pattern, increased opacity, and air bronchograms. Capillary blood gas shows normal capnia and normal bicarb. Note that we don't look at PO2 and lactate at capillary samples as studies show that it does not correlate well with ABG. Blood work shows normal white blood cell counts, hematocrit, and red blood cell count. With all the tests we've done and information we've gathered, let us make a definitive diagnosis. With no signs of fever, no focal consolidation, and normal WBC count, we can eliminate congenital pneumonia, leaving us with TTNB and RDS. Chest x-ray supports a picture of both RDS and TTN, as well as the clinical symptoms such as tachypnea, grunting, and desaturations shortly after birth. Reviewing the history also showed baby is at risk for both. Being born via elective cesarean with absence of labor impedes the fluid absorption because of some fetal endocrine factors we won't get into. It increases his risk for TTN. While being an infant of a diabetic mother will also cause some delay on his surfactant maturity, increasing his risk for RDS. Diagnosis, RDS and possible TTN. What exactly is happening with baby Mo? Due to the deficiency of mature pulmonary surfactant, baby Mo's lungs have increased alveolar surface tension, making it harder for him to open up his lungs. With his collapsed alveoli, ventilation-perfusion ratio is decreased, resulting to impaired oxygenation. In addition, if baby Mo does have TTN, the delayed lung fluid absorption into his lymphatics will worsen his condition even more. Day 1. As per RDS management, we proceeded the technique Ensure to administer surfactant, where we intubated the baby with ATT size 3, initially level 7 at the gum. It is important to make sure that the tube is at the correct position before administering surfactant, to make sure effective administration. Correct position is confirmed when the tip of the ET tube is below the clavicles and 1 to 2 centimeters above the carina on the chest x-ray. At 7 centimeters, ET tube was seen just above the clavicles, so we pushed it at 9 centimeters. And then we instilled surfactant, Cursurf of 200 milligrams per kilograms in the ET tube, and then he was then extubated to CPAP of 8, FiO 2.40. On CPAP, baby is breathing comfortably with clear bilateral breath sounds and vital as follows, and CBG 2 hours after showed normal gases. Perfect. Later that night, baby worsened, having increased work of breathing, tachypnea up to respiratory rate of 90, and desaturations despite FiO2 greater than 50%. Despite putting him on bilevel 23/8, blood gas showed pH of 7.10 with PCO2 of 82. Baby Mo is now on respiratory failure. A decision to intubate was made. After 2 attempts, intubation was successful with an uncapped ET2 tube of 3.5, level 8.5 at the gum, minimal leak noted. RDS management and also emphasizes minimizing lung injury caused by mechanical ventilation. To observe this, ventilator is set at CMV mode pressure control with volume guarantee. This enables us to ensure that Mo is getting adequate volumes at the same time not risking him to have volume trauma. Settings include P max of 30 to make sure we don't cause paratrauma, PEEP of 7 to help open up the alveoli, minimal tidal volume of 12 mils, which is about 4 mils per kilogram, and an X-ray was taken to confirm ETT depth, showing it was at the level of the clavicles, which is too high, so the ET tube was advanced to 9 centimeters at the gum. Furthermore, when comparing with the previous X-rays, we can see how the lungs are wider, plus total loss of heart borders, including more consolidation, collapse, and that the disease have progressed to severe RDS. RDS management, acceptable ABG values are pH of greater than 7.25, PCO2 of less than 60, and PO2 50 to 70 millimeters of mercury. After 1 hour intubation, capillary blood gas showed mixed acidosis. With increased CO2 of 67, tidal volume was increased from 4 to 5 mils per kilogram. Reason for metabolic acidosis is unknown. Because of no arterial access, oxygenation is measured through SpO2 monitoring. As per RDS management, minimizing metabolic demands through sedation and paralysis, along with optimized fluid management, are one of the keys in treating RDS. That is why other management throughout the day includes the following: morphine infusion, and total input and urine output was also closely monitored by our nurses. Day 2. Baby's oxygen requirements increased to greater than 60% FiO2. Blood gas isn't that good either, with a pH of 7.20. In the morning, a second dose of surfactant was administered, and after administration, our baby improved and oxygen requirements increased to 40 to 50%. Blood gas also improved within our acceptable range. It was also reported that afternoon that there is a pre to post ductal difference of 2%. Later that night, blood gas was taken, showing mixed acidosis as shown, so we increased respiratory rate to 45. But another blood gas 4 hours later showed no improvement, so we increased again to 50, and then the tidal volume from 5 to 6 mils per kilogram. Furthermore, oxygen requirements has also been increased. We have already maxed out our ventilator settings, where tidal volumes of 6 mils is not safe for our baby's lungs. We are also starting to reach our set pressure max of 30. At this point, we need to think of alternative or better ways to oxygenate and ventilate our little Mo. Pre-post saturation is getting worse. That night, the baby had an echocardiogram for further investigations. Findings show small patent foramen ovale, a right atrium and ventricle dilation, and higher right ventricle pressures of 50 millimeters of mercury. Cardiologists diagnosed him with pulmonary hypertension. Nitric oxide, a pulmonary vasodilator, was ordered at 20 parts per million. After a few minutes, pre to post saturation difference were only around 2 to 4%. Great. And as we have mentioned before, we have almost maxed out our ventilator settings but failed in improving most ventilation status, and that is why we have decided to switch him to high frequency oscillator ventilation, a more gentler mode of ventilation as high peak pressures are avoided, thus avoiding ventilator induced lung injury. In initiating HFOV, ideally our patient must be hemodynamically stable. Luckily for Mo, he is. Nonetheless, we need continuous monitoring of our blood pressures as the high mean airway pressure we will apply may decrease cardiac output, and this way we can also get a more accurate oxygenation status through arterial blood sampling. So a UAC and a UVC line was inserted. HFOV is initiated. Initial settings is as follows. So mean airway pressure is set as calculated mean airway pressure on conventional, which is 15 plus 2, so it's 17, and assessed on chest x-ray with lung expansion should be seen on the 8th or 9th rib. Along with FiO2, these two settings are what determines our baby's oxygenation. Hertz is set depending on the baby's weight. Terms infants are usually set at 8 to 9. Amplitude is normally set between 20 to 30 and adjusted depending on the chest wiggle factor. Hertz and amplitude will determine our baby's ventilation. And TI is usually default at 33%. Chest x-ray taken shows inflation at the 9th rib. Good job. After initiation, to no surprise, baby got hypotensive with a blood pressure of 51/43, and so epinephrine infusion was started. ABG taken after showed mixed acidosis as shown, with persistent metabolic acidosis and with no definite cause of it, so for now we will just be giving the baby bicarbonate correction. Our lactate is normal and our oxygenation is acceptable. Amplitude was increased to 30 to further decrease our PaCO2. Blood pressure continued to drop, so we just increased epinephrine. And for the baby who was observed to be fighting the ventilator, we added rocuronium. Rough night for a little Mo. Throughout the day, FiO2 was decreased to 40%, saturating within target range. In the morning, the nitric oxide was decreased from 20 to 10 and weaned again in the afternoon to 5 parts per million, maintaining pre and post saturation difference of 1 to 2%. That afternoon, baby had an episode of desaturations to 88, which was secretions related, resolving once the baby was suctioned. At night, the doctor ordered to decrease the amplitude to 34. No documentation about the chest wiggle, but ABG after did not look good. With CO2 rising to 79, amplitude was set back to 36. ABG afterwards showed improvement of CO2 back to 57. Other events include weaning of medications such as the epinephrine, and rocuronium was also weaned but was not tolerated as he was still fighting with the ventilator. Chest x-ray that day looked fabulous. It's significantly more black compared to the previous x-rays. No signs of air bronchograms and the heart borders are much more defined. Good job, Mo. Day 4 was also another weaning day for our baby Mo. He is getting better every day, and when saturations and blood gas shows acceptable values, we challenge him and wean him down as tolerated. At 10 a.m., after the acceptable blood gas is shown, nitric oxide was decreased to 4 parts per million, and will be weaned down by 1 every 12 hours as tolerated. Morphine was also decreased. At 11 a.m., when mean airway pressure was decreased to 16, Mo did not tolerate it with saturations of 88 despite FiO2 of 0.45, and so we went back to 17. Ideally, though, when weaning HFOV, we should include a chest x-ray showing inflation greater than ninth rib with an FiO2 less than 50% as an indication. But nonetheless, at 5 p.m., the blood gas looked fabulous as shown, and so baby Mo is definitely getting better. We wind amplitude down to 36 to 33 and FiO2 back to 40. Baby is saturating 95 to 100% with good chest wiggle. At 9 p.m., we tried weaning MAP again to 16, still with no chest x-ray. The blood gas 1 hour later showed acceptable oxygenation as shown. It also showed hypocarbia with pH on the alkaloidic side, and so the frequency was weaned from 9 to 10. Day 5. Mo is quickly getting better by the day. Here I will give you an overview of all the changes and weaning we made today. Same weaning principles were done, which is to assess through the ABGs, SpO2, and chest x-ray, and also the overall clinical picture of the patient. And through that assessment, wean accordingly using appropriate weaning strategies. We assess response, and if it's tolerated, we adjust accordingly. So for the medication, epinephrine and morphine was weaned, with rocuronium discontinued, and the baby tolerated it and was calm and normotensive. We managed to wean down FiO2 from 30 down to 22, according to the SpO2. Chest x-ray was also done showing lung inflation to the 10th rib, indicating hyperinflation, and so we weaned down the MAP from 15 down to 12, and the SpO2 maintaining still at 91 to 95. Amplitude was also weaned from 31 down to 26, and the frequency up to 10 Hz. ABG taken in between weans shows the PaCO2 trend as seen, from hypocarbia of 33 to normocarbia of 40. Nitric oxide was also weaned slowly, from 2 down to 1 and then discontinued. It is important to note that when weaning nitric oxide, we have to do it slowly. Once 5 parts per million is reached, we wean it slowly by 1 to allow the body to adjust and produce endogenous nitric oxide. Now that we have reached minimal settings on the HFOV, we switched baby to conventional ventilator and pressure control, CMV mode was chosen with volume guarantee on appropriate initial settings as shown. FiO2 set initially at 30 and went down to 21%. Baby is saturating 99%. Perfect. Day 6. Morphine was weaned down, patient awake and active, saturating 99 on 21% FiO2, and leak is up to 70%. We extubated him and he was put on high-flow nasal cannula 8 liters per minute to help him transition smoothly by unloading some of his work of breathing. He has been through a lot. FiO2 was weaned to 21% with baby saturating 95%. There was no work of breathing noted, there is clear bilateral breath sounds, and baby is stable with morphine and antibiotics discontinued. Over the days, baby Mo just continued weaning his high-flow nasal cannula based on his daily capillary gas. On the 10th day, Lil Mo was off his high-flow and was discharged to the wards for further observation. On day 17, March 7, 2021, our healthy little Mo was discharged from the hospital. Great job, everyone! I chose this case study because it caught my interest on how a very sick RDS baby with pulmonary hypertension endured intubation twice, was put on HFOV and nitric oxide, and recovered for a span of 10 days. As an RT, it is always important to identify problems and know why these problems are happening so that we can offer the right evidence-based medicine support at the right time. On the other hand, to actively look for chances to wean the patient whenever we can, and we should always look for indications to wean and challenge the patient. These babies need our support, but we don't want them to be dependent on it for longer than necessary. I also want to note that for the whole hospital stay, the patient did not develop ventilator-associated pneumonia or any sort of infection, which is the last thing he needs. So always remember, proper PPE and hand hygiene is life-saving. Thanks for watching!